Hi, everyone. Welcome. Welcome to the first Bioethics Grand Round, sponsored by the Research Ethics Service of the Center for Bioethics and Social Sciences and Medicine. We're really excited to welcome Ben Berkman here with us today, who's a JD and an MPH, who's also faculty of the NIH Department of Bioethics, where he's the head of the section on the ethics of genetics and emerging technologies. Mr. Berkman has a joint appointment in the National Human Genome Research Institute, where he serves as the Deputy Director of the NHGRI Bioethics Core. He was formerly the Deputy Director of the O'Neill Institute for National and Global Health Law at Georgetown Law, where he continues to serve as an adjunct professor. Mr. Berkman received a bachelor's degree in the history of science and medicine at Harvard University, and subsequently earned a JD and a master's in public health from the University of Michigan. As a faculty member in the Department of Bioethics, Mr. Berkman's research interests span a wide range of topics, and his current work focuses on the legal and ethical issues associated with genomic research, genetic information privacy, and clinical adoption of new genetic and reproductive technologies. So today he's going to come to talk to us about re-examining the right not to know, which I think is very relevant and timely at our institution as we also grapple with those questions. I've seen this talk. I think it's really wonderful and slightly controversial, but in a good way. And also we have great turnout here today. And actually, I'm just sort of curious, this is more of a variety of faces than we often get. Who here is from genetics or genetic counseling? Okay, OBGYN? All right, pathology? Students? Awesome. Anybody else that wants to self-identify? SPH, okay, great. SPH. Awesome, well, welcome. We do this once a month from 12 to 1. So please feel free to join us again in the future, and please join me in welcoming Mr. Berkman.
So thank you for having me. It's wonderful to be back. I was a grad student here 14 years ago, something like that. And it has changed a lot, but it is really nice to be back in Ann Arbor. So as Kate mentioned, I'm going to be talking about the right not to know. I have to say, as a government employee, everything that I say is my view alone. I have a tendency to say controversial things, so I need to make it clear that when I say something controversial, it does not represent the views of anyone important. So let me start here. Most of you probably know this, but the cost of sequencing a genome has dropped precipitously in the last decade or so. Right around 2007, 2008, we had new technology come online that made it significantly more efficient and cheaper to sequence a genome. This is the cost of sequencing compared to Moore's law, and Moore's law, as many of you know, is the idea that computing power will double every 18 months or so for the same amount of money. And if you think about the little supercomputers in your pockets and how much they've advanced in the past decade, and then compare it to the even more exponential improvement in sequencing, we really are in a new world where we can produce massive amounts of information about people cheaply and pretty quickly. And one of the big ethical issues that I've been grappling with over the past decade or so is, what do we do with all that information? And one of the major questions that's been asked is, what do you do when you find something that wasn't the thing you were looking for? And so we've got this idea of incidental findings. Incidental findings are findings concerning an individual or research participant with the potential health or reproductive importance discovered in the course of conducting research, but beyond the aims of the study. So a classic example would be you're doing, say, heart disease research. You're sequencing people to find novel genes that might explain heart disease, and you find that someone has some sort of cancer predisposition. What do you do with that information? Do you have an ethical obligation to tell them about it? And just for terminologic purposes, the idea of secondary versus incidental findings, I think, is important. Incidental findings are things that you happen upon, you happen upon by chance. Secondary findings are things that you actively look for. They're still beyond the aims of the study, but they're important enough that we have a list that we actively look for them. I'll probably make a mistake and go back and forth between these terms. I'm really meaning secondary findings, though, throughout. So just to give you a little bit of a bigger context, we've been thinking about incidental findings for a decade, as I mentioned, well, longer than that, but really actively for a decade. And I think there are a bunch of things that we still haven't figured out. We don't know why we might have an obligation to return incidental findings. We still can't quite agree on that and the resulting contours of that obligation. We don't know how much the research context matters, whether we need to treat studies differently or treat them all, assume that they all have the same standard of care. Do researchers have a duty to look for incidental findings? I've argued yes, but I think we're still sort of moving in that direction. We haven't quite all agreed on that. When is it appropriate to disclose genetic information to relatives of probands, in particular deceased probands? What do you do about incidental findings in low resource settings where they're not actionable in the same way? But the one I want to talk about is how strong is the right not to know? And so let me start with a case. So P is having her genome sequenced, and during the informed consent process, opts not to receive any secondary results. And let me just stipulate here, let's assume it was a decent informed consent process. During their analysis, her research team finds evidence of high genetic risk for non-polyp-forming colon cancer, and they believe that this information will prevent serious disease and perhaps even save her life. And so the question is, and I'm going to ask you to vote here, should they disclose the finding? She said no. She checked the box that said no. Should they disclose it even though she checked the box? So who thinks that they should not disclose it because she clearly indicated she didn't want to know this sort of result? Please raise your hand. All right. And who thinks they should tell her even though she said she didn't want to know? All right, that's about maybe 4-1. All right, 4-1 with a couple people confused. Great. Yes, a question? So, yes, that is the question was, can't there be an in-between where you ask her again whether you want to know? And so I often get that question, and my response is that I just don't know how we'd have that conversation. So, hi, yeah, you checked that you didn't want to know, but we found something. Do you want to know? Well, what is it that you found? Well, I can't tell you until you tell me whether or not you want. And I also think there's some evidence that knowing that someone else knows something important about you really pushes people to accept that you're knowing. So if you want to honor someone's professed decision not to know, having a subsequent conversation where you ask again doesn't really do that. But we can talk more in the question and answer about other possible informed consent strategies that might get around this. I'm going to propose something at the end that I think solves this problem entirely, but we'll see if you agree or not. So great, 4-1, 80-20. I'll show some numbers later. You guys are not that far out of line with the rest of the world. So let me just frame my talk. The big question I'm asking is, are traditional conceptions about the right not to know appropriate in a genomic era? Are there any limited circumstances where it might be ethically appropriate to override someone's expressed wish not to know genetic information about themselves? And how, if at all, should we deal with this in informed consent and return of results policies? And my goal, my thesis, I'm going to defend the idea that we should abandon the notion of an absolute or very strong right not to know that many people in the literature have tried to defend. And I'm going to argue in support of a default for returning high-value genetic information without asking about a preference not to know. And here I need to define high-value information. I'm not talking about Huntington's. I'm not talking about Alzheimer's. I'm only talking about conditions where medical action can mitigate or prevent mortality or serious morbidity, and where there's strong evidence of the link between genotype and significant disease risk. So it has to be serious condition, has to be strong evidence, and there has to be something you can do about it, either on a preventative level or treatment or an intervention. So again, not Huntington's. So I'm going to give you a little bit of background about where this controversy came from, and then I'm going to give you 5 sets of arguments that hopefully convince you that the right not to know, at least the very strong right not to know, is wrong. And then I'll give you some conclusions about what I think we should actually do. So, Act 1, early views. We've been talking about incidental findings for a while now. And this seemed like there were lots of controversies, but this seemed like one of the places where we actually had consensus. Early on, it seemed like everyone agreed findings should only be returned when they're desired by the research participant. And the obligation, if there was one for researchers, was to offer the individual findings to research subjects, which required, an offer would require implicitly discussing the right not to know and soliciting subject preferences. And so here's one formulation: they should only be offered when, during the informed consent process or subsequently, the study participant has opted to receive his or her genetic results. The conception was sort of an opt-in conception. You need to ask the question, and you need to get positive evidence that they want it before you return this kind of information. I'm not going to go through all these quotes, but they basically say, we should only be offering this findings to research subjects, not foisting them upon them. There was an NHLBI working group that wrote one of the first early influential papers on this. And in that working group, they had a minority of people who said, wait a minute, this right not to know thing is we're taking it too far. But ultimately, the majority carried the day, and their recommendation was to always honor dated preferences. So it was in that world, we all sort of roughly agreed. No one had thought about it too much. You only give people things that they want. That seems reasonable, right? And then the ACMG, the American College of Medical Genetics and Genomics, produced guidelines. And I should say that they were couched in terms of clinical sequencing, but predictably, and this was borne out in reality, the research world quickly adopted them as well. And they said that there's a minimal list of incidental findings that if someone's getting sequenced, you should, as a matter of course, look for these findings. It was 57, and it went down to 56, and now it's 59. So the number moves. And I don't want to get into a debate about the contents of this list. I'm not a geneticist. I'm not a genetic counselor. I hope we can all just agree that some list exists, even if it's not this list exactly. And their definition of what they were looking for was very similar to mine: unequivocally pathogenic mutations in genes where pathogenic variants lead to disease with very high probability and where evidence strongly supports the benefits of early intervention. It's a fairly conservative list. By admission, they say that they've left off things they'd like to put on, but they were intentionally fairly conservative. And they argued that variants should be actively sought by the lab, and they called it opportunistic screening. And the big thing they did that was so controversial was argued against soliciting patient preferences about receiving incidental findings, sort of violating the thing that we all seemed to agree about before they published this. And then, at least my world exploded. It seemed like every meeting I went to for a couple of years devolved into literally people screaming at each other about the right not to know. You can see some of the articles that people wrote. My favorite is this bottom left one. It's flawed scientifically and ethically. So basically, it felt like the entire research ethics world, the genetics and ethics world, said, no, we have to have a very strong or absolute right not to know. I'm going to skip these quotes, but they acknowledge that a strong right not to know involves not giving people information that might save their lives. They were okay with the idea that in refusing information, some people might not receive potentially life-saving findings. And they had a bunch of arguments. Their big one was autonomy. I'm going to talk about this in a bit. They made a analogy to the right to refuse medical interventions. They wanted to protect people from unwanted and harmful information and unintended consequences of disclosure. They were worried to some degree about coercion. And there were people that said, the science just isn't there yet. And it's not justified. It's too expensive, and it's not justified. So the ACMG, in response, walked back their position. They surveyed their membership. There was overwhelming disagreement, and they claimed consensus. I can't believe there was consensus, but they claimed consensus among ACMG members that patients should have an opportunity to opt out. And so they updated their recommendations to emphasize that an opt-out option had to be included. And so this debate caused me to start thinking about what was so wrong. I just didn't feel like the right not to know arguments that right not to know proponents were making were that strong. And so I wanted to see how far I could push the argument in the other direction. And so I started doing lots of reading, and I really came to the view that a strong right not to know doesn't make a lot of sense for a bunch of different reasons. And so first, let me go through two arguments that counter arguments that right not to know proponents make. The first is a more philosophical argument. So recent right not to know advocates, when they talk about the right not to know, they talk about it like it's this thing that's been around forever and is really self-evident. But actually, we've really only been talking about the right not to know for about 20 years, since the late 1990s. That was when the first philosophical arguments were made. And there was a substantial literature about this concept in the late 1990s and early 2000s. And actually, if you go read this literature, there's surprisingly limited support for a strong right not to know. There are a couple people, but most of them don't subscribe to that view. Some argue for a limited right not to know that only applies in certain contexts and that can be overridden. And a lot of people argue directly against the notion of the right not to know altogether. So let me walk through some of this quickly. There are a few people, like I said, in favor of a strong right not to know. They typically ground their arguments in autonomy. Right to self-determination implies a right not to know. It seems like they're arguing in all cases, which I'm not sure can be right. They always assume that genetic information has a potential to cause psychological and economic harms, and so it would be rational to not want to know this information. They also raise concerns about inappropriate paternalism and scientific uncertainty, the latter of which I think is a more legitimate critique. So that's, again, just a handful of people taking that sort of extreme view. A larger group of people challenged this broad autonomy-based view of the right not to know and said things like, Rosamund Rhodes said, misunderstandings about the nature and moral force of autonomy have led some in the genetics community to a false conclusion about genetic ignorance. And it's important here, when you call something a right, it's preemptive and value-laden, and we need to be careful about defining the content of rights before we sort of establish them in the world. They're sort of like trump cards. Once you call something a right, it's hard to argue against them. And so once people start calling this a right not to know, we need to be careful. And I think a lot of the philosophers were saying, I don't think this is a right. This is an interest maybe, but not a right. And they argued that autonomy as a basis for this so-called right fails because it unrealistically ignores the fact that there's no such thing as unfettered choice. We can't do everything that we want to do. That's just a ridiculous concept. We're constantly making non-ideal choices. And furthermore, there's no basis for the idea that information alone is autonomy constraining. Just giving someone information doesn't at all say what they have to do with that information, and making that autonomous choice about what to do is really the core nub of autonomy. And in fact, and there's this distinction between knowing and acting. And in fact, I think I'll mention this in a minute, some people have even argued that getting information is autonomy enhancing. If the idea about an autonomy is to make informed choices, getting information will enable you to be more autonomous, to make better choices. I need to discuss Graham Laurie quickly because he is one of these people who talked about a qualified right not to know. He's probably the most prominent person who defended this view. He had this idea about spatial privacy. We have a right to ensure that we're in a state of non-access, and that includes both physical separateness but also sort of psychological separateness, and getting information about yourself that you don't want to know is an invasion of your spatial privacy. But Laurie, who really was a strong right not to know proponent, even Laurie said it's not an absolute right. It has to be weighed with other compelling interests. And he said that it should be given prima facie respect, which should be accorded unless due cause for disclosure can be shown. And when he articulated sort of the case where we might override someone's right not to know, he talked about actionability, he talked about severity, and likelihood of onset. And others also subscribe to this view, this idea that the right not to know isn't something that is absolute, it's something that can be overridden in exactly the kind of case that we're talking about here today. So just to summarize, there were a handful of people who said there was this absolute right not to know. There's a larger group of people who argued that there's sort of a limited right not to know. Then there was an even larger group of people who said this whole idea is crazy, and they made a few arguments. They made an incoherence objection. I alluded to this a minute ago. They said that knowledge is necessary in order to exercise autonomy. You need to know there's a question in order to make a decision. And so not knowing is actually autonomy defeating. And maybe we even have a moral duty to be informed about information that would make a difference in decisions. Again, Rosamund Rhodes was one of these scholars. So that was one objection they made. The other is the third-party harms objection, the idea that genetic information inevitably involves relatives. And so if you're saying, I don't want to know for myself, you're actually potentially harming your relative for whom that information might also be beneficial. And we have we have a different standard when you're potentially imposing harms on other people as opposed to making decisions that are only impacting you. And then a third argument, and this is one that wasn't made in literature, but that I like to make, is that the examples used to support the right not to know, I think they're outdated and I think they're extremely limited. So really, and I'm not exaggerating here, there are only 3 cases that people cite when they're citing in favor of a strong right not to know, and there are these 3 diseases. And I think the first 2 are they're very different than the kind of case we're talking about now. They're not actionable. I think it's perfectly reasonable for someone not to want to know their Huntington's status or their Alzheimer's status. Breast cancer is a little bit more of a tricky case, but I think we've moved away from the idea that it's super stigmatizing and there is something you can do about it. But for a variety of reasons, it drives me a little bit crazy that these are the only arguments that people make in favor of the right not to know, and I don't think that they actually prove what they think it proves, because we're dealing with a different kind of information. It has to be actionable. So bottom line, contrary to what contemporary commentators have been arguing, I think the notion of a strong autonomy-based right not to know rests on an unstable conceptual basis, and really only a handful of philosophers have endorsed such a position, and the majority either argued for a much more limited non-autonomy-based conception or even against the whole concept entirely. So that's to say, I think philosophically, the right not to know is not a terribly rigorous concept. So the second argument that a lot of right not to know proponents make is that we have a well-established right to refuse medical treatment, and that right to refuse medical treatment implies a right to refuse medical information. I think that's wrong. So obviously we have this constitutional right to refuse medical treatment, but there's no actual case law establishing a right not to know. All of the case law that we have is about people using blood transfusions or nutrition and hydration or things like that. And all of those cases are about physical interventions, not information. And the judicial decisions that establish the right to refuse medical treatment anchor their analysis on the importance of protecting bodily integrity, building on informed consent jurisprudence, which is based on the common law idea of battery, unwanted, offensive touching. There's no mention of psychological integrity. Psychological integrity, I think, is a completely distinct concept, at least for constitutional legal purposes. And I think if courts were going to embrace the idea that there's a constitutionally protected right to psychological integrity, they would have to demonstrate that that kind of idea is specifically rooted in the idea is specifically rooted in our nation's history and tradition. And I think they're going to have a hard time doing that, in part because there are multiple domains where courts have already been willing to impose sensitive medical information on individuals. There are the abortion cases where conservative states have passed laws, for example, requiring pregnant women to have ultrasounds, and even if they cover their ears and say they don't want it, the doctor is required to narrate the contents of the ultrasound. Some courts have upheld those sorts of laws. We've had toxic tort cases where people that have suffered, say, workplace injuries that might have some sort of genetic predisposition to being injured. Courts have in a range of cases said, no, you have to be tested even if you don't want to be tested. And there aren't a ton of these cases, but there are a handful of duty to warn cases where people that didn't want to share genetic information about themselves with relatives, where doctors have been held liable for not going and finding the relative and telling them. So the argument here is that the right to refuse medical treatment jurisprudence is built on our history and tradition of protecting bodily integrity, and it doesn't mention this notion of psychological integrity. And in a right not to know case, the question is whether courts would expand established protections of bodily integrity to incorporate psychological integrity. They've been reluctant to expand substantive due process liberty interests. And I think in this case in particular, it'd be really hard to establish the contours of protection for a concept as amorphous and potentially expansive as psychological integrity. And so I think that I think it's really implausible to suggest that courts would accept this idea that psychological integrity deserves the same sort of protection as bodily integrity. So I don't think that we have the same sort of constitutionally protected right to be protected from information disclosure as compared to medical treatment. So I think this idea of a strong right not to know is philosophically shaky. I think the comparison to the right to refuse medical treatment is legally shaky. And so now let me make some more positive arguments about why I think the right not to know is not the best way forward. So first I'm going to talk a little bit about the identified life effect, then I'll give you a comprehensive analysis of harms and benefits that result from adhering to a strong right not to know position, and then I'll talk about moral distress and genetic exceptionalism briefly. So identified life effect is the idea that if you, in the abstract thing, people value things more differently than if there's a specific identified person. They're willing to save a lot more money. They're willing to pay a lot more money to save someone with a name and face than they are to save someone who doesn't have an identity. So earlier I asked you the case. Let me ask you this question. Do research participants have a right not to know their own genetic information? In other words, would it be acceptable for them to choose not to receive any genetic incidental findings? I'm not going to ask you to raise your hands because I've already polluted my sample pool here. But I gathered some data. I asked people that question, then I asked them a version of this case that I asked you earlier. And here are the results. These are all IRB people that are IRB members or chairs or that do IRB work. And the important thing, I don't know if I have a pointer here. I do. So when we asked them that baseline question, is there a right not to know broadly, 96% said yes. And then when we asked them the case, it dropped down to 63. So you guys were at about 80%. So you're roughly in the ballpark, but that's a pretty significant, still a majority of people said you shouldn't return the information because she said no, but dropping from 96 to 63 just by giving the case some more details and making it an actual person, I think is significant. The number of people that said there wasn't a right not to know jumped from 2 to 26, and we had some people that were confused, so they get put in this pile, the number of people that were just confused. Right, well now if I had done the actual experiment, there would have been a bunch of other people to join you. So I think this says a few things. I think, first of all, An absolute right not to know makes a lot of sense in the abstract. People love rights. People love rights, particularly when they get to control what happens to them. But I think that views change, and change pretty significantly, when presented with actual cases where there are stakes, where there's a piece of life-saving information available. And so I think that this at least suggests that conceptions of the right not to know shouldn't be expressed in such absolute terms. I also think it has implications for informed consent. I generally hate checkboxes in informed consent documents. I think they're terrible, but I particularly hate them in this context because I just don't think that asking people an abstract question about whether or not they want to know secondary findings is actually going to capture people's views and preferences accurately. And so I'm not sure that we should have these binary checkboxes. And I should say at NIH, that's what the vast majority of investigators do. They have a 1 or 2 sentence description. We might find secondary findings that could be important for your health. Would you like to know them? Check 1, yes or no. I'm not making that up. That is the way a vast swath of the research world does things. So I'm not confident that the way we're doing, I'm not confident that people's views on the right not to know are as strong as we might think, and I'm not confident that the way that we're collecting preferences makes a lot of sense. So let me now get sort of into the meat of my argument. And really the question here is when psychosocial concerns should get to trump the prospect of life-saving intervention. And one of my problems with the literature as it stands is that the focus on an autonomy-based right not to know, the contemporary literature, the post-ACMG literature, the focus on autonomy has sort of had the effect of short-circuiting discussion of the topic. We're focusing just on the harms associated with not honoring someone's expressed desire not to know. And I think that we need to broaden our approach and look both at the harms and benefits of honoring or ignoring the right not to know. Because you're going to make one of 2 mistakes. You're either going to give someone information that they said they didn't want to know, or you're going to lose an opportunity for medical intervention. And I don't think you have to make one of these 2 mistakes, and you have to figure out which one you're more comfortable making. And in order to figure that out, I think you need to ask 3 questions. How many people genuinely wouldn't want to know genetic information about themselves that could have a profound impact on their morbidity or mortality? Second question would be, if people were given information that they would have preferred not to know, what is the actual magnitude of that harm to them? And third, if you give people a choice, how many people would erroneously or accidentally not receive potentially life-saving information? So I think if you answer these 3 questions, then you can decide which of those 2 mistakes you want to make. And I come down pretty clearly on one side, as you'll see. So to the first question, let's look at some data. I think the number of people who wouldn't want to know this kind of important genetic information is minuscule. The overwhelming majority of people want to be given genetic risk information. In one study, it was 96%. Another study was 98%. And in these same studies, they asked people if they wanted information that wasn't actionable, and those were still very high numbers in the 80s, I think. The Kaufman study was at least 1,000. They were pretty big studies. They were surveys of the general population. Yeah, these are both surveys of general population. And I'm just citing 2 here. There are other studies that back this up, that back up this idea that most people are really So I think Peter's raising this concern that maybe this is a biased sample, and certainly people that are interested in doing genetic research, particularly earlier, are probably information seeking, so you want to be careful about generalizing from them. But these, I think, were ascertained from a broader cross-section of the public. But I'd have to go back and look to see if there was any sort of bias. So, right. So my argument is that group of people is very small, and so it's very hard to study. I'm about to launch a survey that I found 150 of them in a large study that checked the no box, and so I'm in a month or so, our survey will go in the field, and I'll be able to give you a better answer about how we can characterize those people as compared to this larger group. But since most genomic studies that are doing sequencing are sequencing dozens of people, maybe 100 people, and if only 1 or 2% say no, it's hard to do systematic research on that population. So hopefully I'll be able to give you a better answer next time I give a talk here. So my argument is that this is a tiny group of people that don't want to know this information. Really, we're talking about the very end of the tail of the curve. And I think that if you look at this group closely, I think that most of them are probably going to be individuals for whom clinical action might not be indicated. People with terminal illnesses, people who are very old, people with religious objections to receiving medical treatment. These are oft-cited examples when people are arguing in favor of a strong right not to know. Well, this kind of person might not want to know, so we need to ask everyone about whether or not they want to know. And I don't think that's right. I think we should bracket these cases. I think these are all relatively easy to identify, and I'm fine treating these people different, but I don't think that the fact that there's this tiny group of people, most of whom we can identify and bracket, is a reason for driving a right not to know policy where everyone has to get asked whether or not they want to know. So I think that it's a tiny number of people who wouldn't want to know, most of whom can be bracketed. The second question is, if you give people information they don't want to know, how much do you harm them? And people generally talk about depression or anxiety or stigma or discrimination. So thinking just about psychosocial harms here, I think the literature is pretty clear. There's this idea of effective forecasting, the notion that we are terrible as humans at predicting our future emotional state when faced with bad events. We think things are going to be terrible when we underestimate how adaptable we are generally. And so in the context of genetic information, there's been a ton of research, and generally they find that even in cases where there's nothing they can do, that the psychological impact of getting bad, unfortunate genetic information is that people are minimally upset for not very long. So a minimal and transient negative psychological impact. And in one review article, they said that society is systematically overestimating the durability and intensity of the effective impact of events on well-being, resulting in a culture of risk aversion in which patients may be opting out of potentially beneficial diagnostic and treatment regimes. I think we're not giving ourselves enough credit for our ability to adjust to bad information, and so I think we're overestimating the psychological impact of receiving bad, unfortunate genetic information. From an economic harms perspective, i.e. discrimination, we've got GINA, and even though there's a lot of evidence, there's a lot of data that says people are actively afraid about discrimination, employment discrimination, or health insurance discrimination, and so fear of discrimination is really high. There's just not that much evidence of actual cases. And there are more cases, I have to admit, in the context of life or long-term care insurance that aren't covered by GINA. But systematic reviews that have really tried to find widespread problem say things like, with the notable exception of studies on Huntington's disease, none of the studies reviewed here brings irrefutable evidence of systemic problems of genetic discrimination that would yield highly negative social impact. So I need to be careful here. I'm not saying that there's never going to be a problem with genetic discrimination. I'm just saying that right now there's not any evidence to suggest that it's a widespread problem. And so when we're making decisions about research ethics policy, I think we should make a clear-eyed assessment of the frequency and magnitude of any economic harms before we automatically assume the worst case scenario. So I don't think psychological harms are as bad as we think they are. I also don't think economic harms, at least right now, are as bad as a lot of people think they are. And then the third question is, on the other side of the ledger, what happens if we do ask people whether or not they want to know? Are people going to make mistakes? And I think there are some serious challenges in ascertaining preferences. Just in general, this is sort of terrifying, but if you read the literature about people's understanding and engagement with consent documents broadly, people don't understand basic concepts like randomization or that they're in research. So people are pretty terrible about engaging with consent forms. In particular, there's a lot of evidence that people are terrible about engaging with the complexity of genomic information. And we've had lots of people try to describe different buckets, and I don't think any of them are particularly intuitive or are very good at getting people to understand a wide range of the types of genetic information that one might find. And then there's this problem of capturing uncertainty and shifting preferences over time. If you ask someone what they want to, asking someone who's unmarried at 20 and is a student, you might get a different answer than 30 and engaged, get a different answer than they're 40 with 3 kids. I mean, these are all people's views change over time, but you're asking them in the context of a 15-page consent form to check a box to make this binding decision, which of course they could go back and change, but no one ever does. And so I don't think that preferencing these check boxes as this absolute assessment of someone's preferences is a very good idea. So overall, I'm sort of skeptical about our ability to actually capture people's preferences in a meaningful way. I think that some set of people are going to make a mistake and then are going to forego the opportunity to get potentially life-saving information. So, bottom line, there's a very small group of people who don't want to know that I think we can deal with separately. I think the risk of harm is minimal, and I think there's a real risk that actively soliciting preferences about a right not to know could result in people making choices that don't actually reflect their true values and preferences, thus erroneously or accidentally not receiving potentially life-saving information. 2 more quick arguments. Moral distress. This is I call it the I can't sleep at night problem. When a clinician has a piece of information or knows they need to do something that they're for some reason prohibited from doing, can lead to something called moral residue or burnout. And here, I don't think this is dispositive, but I think while patient autonomy is important, provider morality is also important, as Ed Pellegrino has written about. And so I think it's one more data point in favor of my view that the right not to know should be questioned. Similarly, genetic exceptionalism. I think we've had a strong refutation of this idea of genetic exceptionalism. And people that are arguing in favor of a strong right not to know are really arguing that return of any genetic information requires treating this kind of information differently. Because it's standard practice in a lot of medical contexts to give people information without asking their permission first. And so it seems fair to ask whether this instance of genetic exceptionalism is warranted. 2 examples, if you have your abdomen screened, imaged because, I don't know, you have a broken rib and they want to see if it healed and they discover maybe there's a mass somewhere. They're not going to say, hey, we might have found something on the imaging. Would you like to know? They're just going to tell you that they found something. Similarly, if you're getting a blood panel for a particular reason and they find a panic value in the panel for some unrelated thing that they weren't actually thinking about initially, they're just going to tell you. They're not going to ask you. And it's not a perfect analogy with the genetic information because they're not generally associated with conditions that require immediate attention. And genetic predisposition isn't the same as diagnosis of a manifested disease. But I don't think the question is whether the information is precisely analogous to urgent cases like I just discussed. I think the question is why we should treat this information differently than we treat the vast majority of medical information that we routinely return to people without asking. And I think, given the thorough rejection of genetic exceptionalism, that the burden of proof lies with right not to know proponents to make that case, and I don't think they have a very good answer to that challenge. So let me just conclude. I think this is the way. You might disagree with me. I'm happy to have people disagree with me. But I think if you're going to disagree with me, I at the very least need you to engage with all the questions I asked. So on my view, it's a tiny group of people that don't want to know, that have low magnitude harm if you actually tell them the information they say they don't want to know. And at least in my mind, the cost of a strong right not to know, of asking people whether or not they want to know, outweighs that potential harm. Maybe you disagree, but I think you need to have an analysis of all of those questions in order to counter me. So let me give you my sort of bottom line. I think the prevailing autonomy-based view of a strong right not to know is wrong. I think it's philosophically shaky. I think the legal right not to know is questionable. I think popular opinion is going to shift as we get more and more cases that demonstrate the utility of this information. I think the strong right not to know would do more harm than good. And I think other considerations like moral distress and genetic exceptionalism weigh in favor of a more limited view. I can't, however, endorse a pure beneficence view where we just tie people down and tell them information over their screaming. I am a bioethicist, so I can't endorse that view. I think it's too paternalistic to force information on someone who's actively resisting. But I don't think that means we have to ask them the question. So I'm more in the libertarian paternalism area, this sort of nudge idea. Not quite there, but you'll see in a second. You could give people a choice not to know, but define a default package of recommendations and then ask them whether or not they want that. I think that's a pretty good option, although my objections to whether or not people really understand what they're being asked, I think, still stand. And so my view is somewhere between beneficence and libertarian paternalism. I think for high impact genetic information, again, not Huntington's, we shouldn't actively solicit preference. We just shouldn't tell them. We should tell them it's happening, but not ask them. So consent forms would say, we're going to sequence your genome. In the course, we're going to look for these 57 things. And if we find one, which we expect to find in approximately 3% of cases, we're going to tell you. Like, that's it. No question, no checkboxes. And then in the rare case when someone reads that and says, I'm not comfortable with that, that's fine. Let's talk to them about it. Ensure they really understand what they're saying no to. But ultimately, if after that conversation, which I think would be exceedingly rare, someone really doesn't want to know, okay, I'm willing to bite that bullet. That person, we can honor their right not to know. But I think generally as a default policy, we shouldn't be asking the question. And then just finally, bracketing the question of whether the right not to know exists in any circumstance, at least let's stop talking about it as such an absolute concept. I think that's wrong. For any high impact information, I think deviation from regular disclosure should be a clearly defined exception rather than the basis for a broadly applied conception of the right not to know. And this is part of a larger project. I just think that we should be more skeptical and challenge the idea that psychosocial harms or potential psychosocial concerns should automatically get to trump the prospect of life-saving intervention. So thank you very much. I would love to hear your questions and challenges. Am I required to mention the president? This is being recorded, so I'm going to not answer that question. Yes? Right. Mm-hmm. So you're really asking me, can I propose something to fix the entire healthcare system?
Yeah, actually, it's fantastic, but yes, that.
Sure. So I have two responses. The first is to say that I draw a distinction between information and action, and so I think knowing the information doesn't require you to go get screening, doesn't require you to go get interventions. That is a separate decision. And I'm only talking about the provision of the information that can potentially help them make better choices. But I think you're also sort of getting at this idea about actionability being variable depending on the context. So someone that doesn't have insurance. We do a lot of research at NIH in Africa, in communities that don't have any access or barely any access to medical care. And so does actionability, should we have the same standard for actionability in different places? And I'm willing to, at least in the low resource setting, I'm willing to say that we should be more open to asking people about whether or not they want to know if there's really no chance that they could act, they could use that information in a clinically beneficial way. I just had a paper come out in the Hastings Center report that talked about this, but I think we should be really careful about not making assumptions about actionability just because someone doesn't have insurance or lives in an area where it's going to be really hard to get medical care. Doesn't mean they're not going to be able to get it. And again, there's just information that I'm sort of skeptical about the psychosocial harm of giving to people. So I'm sensitive to your critique, but I think, and I'm willing to relax my view on the right not to know in certain circumstances. I just think we need to be not make too many assumptions about people's ability to actually get care and act on these findings. Yes. Yep. So do I think that researchers have an obligation to share information with relatives when we're talking about this high value information? That's a good question. So I think generally it's really hard to argue that a researcher has an obligation to someone with whom they don't have any relationship. I think that research is different than clinical care in a lot of obvious ways, but one in particular is that you've got to protect your researchers' time, and having them hunt down all the relatives that might be impacted by this, I think, is a bridge too far. So I would argue that they don't have an obligation with a living proband to do anything other than tell the proband and say, this is really important information that you should share with your parents and your siblings and your children, or your cousins or whatever. But then let's also talk about the case of a deceased proband. I have a different paper about that. I think there you can make more of an argument that there is a responsibility for the researcher to at least find one member of the family. So let's say they're analyzing someone's genome who has recently passed away. So there's no proband to give the information to share with the family. I think there you can make an argument that they should probably try to find the executor of the estate or a child or a spouse to just say, look, we found this and this could have important relevance to your family. And so, but only find one person and then again have them share it with the rest of the family. That's roughly my view. Yeah. Mm-hmm. So that's really helpful. Having a public health degree myself and having thought a lot about public health ethics, that really resonates with me. Living in a biomedical ethics world, I think what I consciously or subconsciously tried to do was sort of sneak that in there, but yeah, I could make it more explicit, and I think generally what I'm trying to do is saying, let's look at this on a population level And if you have a policy that you ask people, I think on net, you're going to do more harm than good, even if some individuals are going to be disadvantaged. So I think that's sort of implicit in the way I've constructed my analysis, but I could make it more explicit. And yeah. Yeah. Right. The way the science is going, my argument would only get stronger and stronger from that public health ethics perspective. Peter, yes, last question. Thank you.
I would sequence my genome unless I'm giving general permission.
Mm-hmm.
So again, back to the denominator, we're dealing mostly with people who want the information. Not correct?
So a lot of, there are different groups of people who are being sequenced. There are volunteers in studies, healthy volunteers or affected volunteers that aren't acutely sick. And they would probably fall in that category. They're doing it out of altruism or curiosity. They're probably information seeking. But you've got people who are participating in research because they're more acutely ill, so rare disease patients or a lot of cancer patients who are getting sequencing done. Sort of, even though it's research, it's sort of adjunct to their treatment, and so.
Okay, then that gets your fault. This is very.
Well, I think it's.
Now, by saying, well, I want the checkbox for the incidental finding, but I sort of want to hide.
I don't want any checkbox ever, but I'm willing to listen to people that are able to. No. Well.
But then back away from it by saying, well, I really don't want to talk about it.
Well, so
Hello?
I think so maybe we're quibbling about whether there's an extra sentence in my minimal paragraph that says, and some people are worried about discrimination or stigma or things like that. My argument is that kind of risk, because I think it's fairly minimal and fairly remote, it's not necessary. We don't mention all risks in consent. And that is a fight I've. Yeah. Right. All right. Thank you.